All right, let's get started. So we're going to pick up where we left off. And that is talking about why cultural competence is important for the client and the therapeutic relationship. So let's go to our screen share. Make sure you signed in after break. And that, of course, is for those of you all who are in the training live. All right. So the importance of the client, of cultural competence where the client and the therapeutic relationship is concerned. Culturally responsive services displays honor and respect towards the client. You know, it means a lot to all of us when we know people are interested in and take an interest to even to the extent of educating themselves or finding out more about us. And so this displays honor and respect towards the client. Culture is embedded in the client's language and the client's verbal and nonverbal communication styles. And so we want to, for instance, a client who is from a culture where eye contact is considered disrespectful. We don't want to, coming from a culture where eye contact is shows respect, we don't want to try to force eye contact from a client where whose culture indicates that eye contact is disrespectful. But if we don't know that about the client, then we may find ourselves thinking that they're just low self-esteem or shy, and try to force them out of that. And that's going against their culture, wouldn't be showing honor or respect. And so we want to be sensitive to both their verbal and nonverbal communication styles. Also, language accommodating services. We saw that in the video. Translation and interpretation can have a positive effect on the client's responses to treat and subsequent engagement in recovery services. And so if they don't understand, just like if we don't understand what they're saying, it hinders the relationship, the therapeutic relationship. So it is if they don't understand what treatment, what this is. It may feel like incarceration to them. It may feel like a punishment to them. And so in order for them to have a positive treatment experience and to become engaged in recovery services, they need to have a translator or interpreter. If that's, if they need that, then that needs to be provided. Cultural competence can enhance trust and establish rapport in the therapeutic relationship. And then culturally competent professionals and organizations have the capacity, and we're going to talk about capacity in just a moment, have the capacity to function effectively within the context of the cultural beliefs. Cultural beliefs are our clients' cultural beliefs, the beliefs of the culture within within the arena that we work. We want to be competent to function within the context of those cultural beliefs, the behaviors, and the needs presented by consumers and their communities. And of course, there has to be boundaries, and we'll get into talking about boundaries a little later in the training. But capacity, building capacity. When we talk about capacity, the ability to address identified needs. The capacity is resources plus readiness. That's what equals capacity. And so resources, programs, organizations, people, money, expertise, and other resources that the organization and the professional possess, enabling them to address the substance abuse and other presenting problems. And then readiness, how ready the organization and the professional is to take action and commit its resources to addressing these problems. So sometimes we can have resources, but not have the ability or to take action and commit to the resources. So you may have a list of resources for particular, for the use of the clients, but you don't have anyone in the agency, you don't have enough people in the agency to execute action to help the client engage with those resources, then you're not ready. And so therefore your agency would not have the capacity, or you would not have the capacity if you have all these resources, but you don't have the time to walk the client through being connected to those resources. I think about how they began to institute early in my career as a professional, substance abuse professional. They began to institute the case management role because the counselor couldn't carry the weight. The counselor didn't have the capacity to provide the treatment services and do the case management work. And I remember initially the friction that existed between case managers and counselors, kind of on the order of recovery coaches and counselors, where at first, the first introduction of that role seemed to, for some counselors, seemed to be threatening, when in actuality, it was designed to take some of the weight and the load off of the professional counselor, so that the client could have the best of both worlds and be able to access the resources that were available in other areas that the counselor did not have the time to walk them through. Has anybody experienced that, where you had resources but didn't have the time that was needed to walk the client through? You weren't ready. You couldn't take action and commit to those resources because you just didn't have the time. Resources plus readiness equals capacity. Cultural competence awareness. Cultural competence describes the capacity of an individual or organization to interact effectively with people of different cultures. Many of us may be familiar with the cultural iceberg, where 10% you see the 10% that's easy to see, the customs, the morals, the courtesies, but up underneath are the values, the priorities, and the assumptions. And these are the things that are more difficult to see. And so the elements of culture are norms, values, beliefs, symbols that culture ascribes to, and practices. We're going to take a look at a video.
We were kids who were placed in the system and we were expected to function like every other normal kid in the United States. But in reality, we were normal kids. We didn't have any physical deformity or anything visible, but we had scars that were invisible. A lot of them did not make it. Some of them died because of they joined a gang. Some didn't make it through depression. I think, overcoming all, when I look, I see, like a kid, we had the war. Kids are, to be seen but not to be heard from. So nobody was comforting us or, there to attend your emotions and say, you went through war, you watch people blown into parts, We lost our belonging, our home, our whole identity. But this is why nobody ever said that. So it just left us alone. And then we came here, and here in the United States, people are like, oh, here's your physiology needs in your home and everything. But you're forced so much to just be your own self in a short period of time. And all you hear is, why are you not assimilating? Why are you not becoming? But that time is when I felt like when we were our worst self, it's when for the first time, we were no longer, as a kid, I was no longer watching after my sibling. I was no longer worried about water or food, or if my mother would get to a medical, facility every time she had a miscarriage. So after all that, responsibility was no longer on my shoulders. I was forced to face me. My highest point will be who I am today. Yeah. Now that I am an interpreter myself, working in Maine, I find that a lot of people would put me under the category of an expert. And I used to say that, what qualifies me to be an expert? I'm just a Somali person. I learned what Somalia is and how their government was working, whatever. Like any other American person, I Google a lot. Even though we have one culture, one language, whatever, we also have different cultures individually. Every household have their own little culture, that the way they raise their kids, the way they go about the Islamic religion is different than the next door. So not to assume that we all dress alike, eat alike, talk alike. It's not the case,
This is Najma, a 20-year-old woman from Somalia. Last year, Najma and her husband were set to be resettled by the United Nations to Lewiston, Maine. 2 weeks before their departure, Najma's husband died of a respiratory infection he contracted in the refugee camp. A month later, now in Lewiston, Najma discovered she was pregnant. Najma's neighbor urged her to make an appointment to see a doctor. She said it was very important for the health of Najma and her baby. In Somalia, people only see a doctor if they feel sick, but trusting her new friend, Najma made an appointment. The receptionist told her to come at 2 o'clock on Tuesday. She had errands to run till 5, but in Somalia, patients wait to be seen, sometimes in the order they arrive, sometimes at the discretion of the doctor, sometimes for hours, so coming later would just mean someone else would get the chance to see the doctor first. The errands took a little longer than expected, so Najma arrived at 5:30 and was flustered to find the clinic had closed. When Najma called the next day, the receptionist said that they closed at 4, as always, and that Najma needed to show up the next day at 10 a.m., or else there'd be no time for her for a month. This wasn't anything like the system she was used to. Najma felt terrible being spoken to like this. She hadn't meant to convey any disrespect to the receptionist, and she was frustrated because she had no idea why she, a healthy woman, was going to the hospital anyway. The next morning, Najma took a little longer than normal getting out of bed. She'd been sleepy in the mornings lately, but she was only 15 minutes late, so she figured she was close enough. The receptionist did not agree. She rebuked Najma for her selfishness and lack of respect for others. She then handed Najma a clipboard of forms to fill out and sign. None of this made any sense. In Somalia, there are no set appointment times. Doctors take as long as they need with each patient, and then call the next in line. There aren't any forms to sign because records are seldom kept. Najma wondered if the forms meant she was in trouble. She could speak and read simple English, and the forms had many questions about her family and her past. Some questions were very personal. Were these questions for the police? Would they be used against her? She wished her husband were here to handle these things. She felt like there was no one to help her. She did as she was told and filled out the forms, hoping not to get into any more trouble. Najma's name was called by a cheerful woman who introduced herself as a nurse. She didn't know that word. The nurse did things Najma expected the doctor to do, taking her blood pressure and pulse. She asked more personal questions. Then she left, saying the doctor would be along. Najma waited 10 minutes for the doctor. Why had the receptionist been so angry about Najma not arriving on time if she was just going to be kept waiting? Why not just come get her when they were ready? In Somalia, the powerful often kept subordinates waiting. She guessed that's what was happening here. The doctor finally came. Najma was relieved. The doctor looked at the computer and then examined her a little. She said Najma showed signs of anemia. She told her she was ordering a blood draw for a full CBC and a prenatal panel. Najma didn't understand any of that, except bloodletting, which was a treatment in Somalia sometimes. She didn't feel sick, but the doctor said she had something wrong with her. She was embarrassed and scared to ask the wrong questions, so she didn't ask what it was. The doctor left, and a lab tech came and took some of her blood. After the appointment, Najma was confused about who her doctor was. In Somalia, you only saw the doctor, but there were so many people here, and the one she spent the most time with was the nurse. Was the nurse the doctor here? Najma got a call 2 days later from the nurse, saying they wanted to test her hemoglobin and ferritin levels. The nurse also said they would send her a card telling her what foods to eat. Najma got the card titled Iron-Rich Foods. It was full of strange foods she didn't eat and didn't know how to cook. She knew some foods were used as medicine, but she didn't feel sick, and she ate good food anyway, so she threw it away. Somali doctors typically call patients to schedule follow-ups, so when the doctor never called, she decided to take it as a blessing and be done with it. Nothing helpful had come from her visit, and it had been very unpleasant. A few weeks later, Najma's neighbor got to asking how the appointment had gone. She was dismayed to hear what a catastrophe it had been. She took it upon herself to phone the office and schedule another appointment for Najma. In the interim, the entire healthcare team at Najma's clinic had attended cultural competency seminars conducted by Maine intercultural communication consultants, and they'd learn how to better treat patients like Najma by examining their own culture, learning about Somali culture, and discovering the many unexpected ways culture shapes us all. They also learned cultural bridging techniques to communicate their messages more effectively, as you'll see in a moment. This time,
I want to stop there for a minute, and then we'll look at the rest of it. Comments on the video. The first young lady spoke about how when they were brought into the country that their physiological needs were met, which is the first tier in Maslow's hierarchy of needs, addressing basic needs. However, we don't want to be insensitive to the importance of other needs. And as we saw in the last slide, talking about the importance of not having misunderstanding. And so in this second part, the second case study on the video, we see that there was a great deal of misunderstanding because and even the receptionist was rude. I don't care what culture you come from, but in America, things are done quite different than in Somalia. And so there was misunderstanding or no understanding for the client in terms of what she was faced with and what she was dealing with. Comments. Taylor Gallup, want to make a comment on that?
Sure. I understand the importance of that completely. Just negotiating the barriers is so important between the cultures, and having somebody who's competent to be able to do that sort of thing in any clinical or healthcare setting is vital.
Yes, absolutely. And you could see how she could be frustrated, the patient, so frustrated because of what she expected as opposed to what was the cultural norm for the American culture when she was expecting a call back from the clinic for a follow-up. Patrick.
Is it presumptuous of us as U.S. Americans that we expect everybody who comes here to understand our cultures and understand the processes here? Do you think we have that attitude as Americans?
I think we do. I think that our culture is one of a desensitized culture when it comes to others, and even an attitude of entitlement, maybe.
I thoroughly agree, but that's what my exact like thought process and question was going to be. But then I think back to your statement of, we need to be our client's clinician. That's the same thing with a doctor. Your doctor's supposed to be your doctor. And so I 100% agree. I think the American society is very selfish and it needs to be this way. Whereas we would function stronger if we were meeting people where they are.
Absolutely. Absolutely.
Okay.
If we were sensitive to the needs of others and not so westernized in our mindset, we could embrace other cultures more readily if we were open-minded. And so desensitization is a real thing. Becoming desensitized, we can become desensitized as healthcare providers, as we deal with so many cases of the people from the drug culture, right? And see so many relapses, and we hear so many of the same stories repetitively, different person, same story. If we're not careful, we can become cold and desensitized to where we begin to deal with everybody in a cookie cutter fashion and without becoming that person's therapist, And another thing that lends to desensitization too is having a heavy load and not really having the ability to take the time that's needed for the client. The video talked about how in Somalia, the doctors took as much time as needed with each person. Well, that's not normal here. You get rushed in and rushed out. And when you find a doctor that's not that's not in a rush to get you out so they can go to the next person. I mean, it's like drive through McDonald's. Like, they're trying to hurry you along because they're on a timer as to how fast they can get people through the line. And so that seems to be the climate of our culture in America. So let's look at the outcome of the video.
The receptionist gave Najma a reminder call for her appointment, and she explained that the doctor only had a short time with each patient before the next one. Each patient had to be there on time or they'd miss their spot, like you'll miss the sunset if you aren't there to see it. This was different for Najma, but it made sense. She was always on time to appointments after that. When she got to the clinic, the receptionist told Najma why she had to fill out those forms. They were for records, so the office could remember every patient over time. Sometimes doctors could look back and solve illnesses that a doctor without records couldn't solve. And if Najma got a new doctor, he or she would know all about her. She told Najma the information was confidential, which meant it could never be shared without her permission or used against her. The nurse explained her role to Najma. She was part of a big team that worked to keep lots of patients healthy. She explained why patients sometimes have to wait for the doctor. She told her that some patients need extra care, or sometimes emergencies happen, but by being ready in the room, Najma could see the doctor as soon as possible. The doctor came in, and this time she explained anemia and how even though Najma didn't feel sick now, it could make her very sick later. It was hard for Najma to understand being sick without feeling sick, or the idea of curing an illness in the future. But the doctor explained how they could see the causes of sickness before they were felt and before they were dangerous. The doctor said she'd like to do more blood tests and explained what could be learned from those tests. She asked Najma if that was okay. Najma's doctor provided her with another list of iron-rich foods, but this list was developed in partnership with members of the local Somali community. It featured foods that Somalis ate and could buy locally, and some recipes too. Najma recognized some of the foods as being fed to pregnant women in Somalia, and now she understood why they were good for her. Najma asked the doctor if she could be a community partner too, so she could help patients like herself understand how to get the care they needed. The doctor said that would be wonderful. Remember, no one knows everything about every culture, let alone every individual within every culture. But by increasing your cultural competency, mistakes can become opportunities for learning and authentic human connection. Working cultural competency into all levels of your practice, gaining insight into your own culture as well as others, and using the cultural bridging techniques like the ones discussed here will allow you to serve all patients with the best, most equitable healthcare possible.
So let's talk about how we can, as clinicians, working with the substance abuse population or the homeless population, how we can help them. I see, Ariel, you said you ended up making packets on your own time to make it easier. Can you elaborate on that, please?
Sure. So one of the things, I was working in like Midtown, downtown Detroit area, and clients were asking for things like, quick money making tips, because most of our clients at the time were homeless. So quick money making tips, resources for mental health that didn't include like medication regimens, just like individual therapy. So because I had gotten so many of the same questions, and I obviously, we were overwhelmed and didn't really have the case management time, I made packets on my own time. I made packets so that whenever somebody asked me that question, I would pull out a packet and be like, yeah, here's a ton of quick jobs in the area. Here's a list of doctors that take your insurance. Here is like a packet of individual therapy. And I would tell them, like, if you need to make these phone calls, you and I can make a script together. Because in that way, it only takes like 10, 15 minutes to like make a script with them that is personalized. But then that way I didn't spend all of our office time finding those resources, teaching them how to use them, what have you. So we would make packets based on the area to resource manage.
That's awesome. That's awesome. When we looked at the video, they adjusted to not just Somalians, but realizing that they obviously realized that they had been taking it for granted that people understood the difference between the nurse's role and the doctor's role. Why there's such a long wait in waiting for the doctor to come in after the nurse leaves. What the foods were that these foods were not familiar to everybody. And so they, there's a certain cultural humility and that a role that they took, becoming culturally humble to realize I don't know everybody's culture and everybody is not in tune with my culture. So I have to go the extra step as the provider, as the healthcare provider. And that brings us to a place of becoming culturally sensitive. Let's get back to our PowerPoint. So when we look at the iceberg and just in thinking about the video that we saw, at the tip of the iceberg, we could clearly see the young woman's age, at a good guess, her clothing, which said a lot about who she was, where she, that she was not of American ethnicity. We could see her gender and be pretty comfortable with that. She was pregnant, so we could see some physical characteristics, and we could see some behaviors, but for the most part, we couldn't see her personal beliefs, which is when we look at personal beliefs, it's way down here at the bottom. We couldn't see her personal beliefs. We couldn't see her worldview. We couldn't see her assumptions. We couldn't see her thought patterns or her family attitudes and values, you know, her personal values. The young woman in the first part of the video talked about having her physiological needs met. That may have been up here at the tip of the iceberg, that they needed a home, that they needed to be cared for. They were homeless, and that. But she talked about how as things began to progress, she no longer had to watch her siblings and look after her mother's health. And these things, though they may have looked like burdens to the healthcare professional, they may have looked like burdens upon her, upon the young woman, but it may have very well been her personal values in terms of validating her worth. And when these things were no longer necessary for her to do, she talked about now she had to get in touch with herself, which is at the tip of Maslow's hierarchy of needs. I'm not sure if you're familiar, but Maslow's hierarchy starts with the physiological, then safety is the second tier, establishing some stability. And then the love and belonging, her love and belonging may have been rooted in what she did for her family. And when that was no longer necessary, it may have affected that fourth tier, which would have been self-esteem, her value of herself. And then ultimately coming into self-actualization at the final tier of Maslow's hierarchy. She may have had a really hard time with that, considering that we would take for granted that removing the burdens would give you opportunity to self-actualize, but without developing a sense of love and belonging and self-esteem, self-actualizing is not even possible. So what we're looking at then is life experiences. These are things under the iceberg that we have to dive into and seek to understand, because it's not evident at the tip of the iceberg. It's not visible. It's less visible. In fact, most of this is at the point of not visible at all, without some conversation and some interaction and diving into those thought patterns and getting to know that person. I like pictures. Pictures say a whole lot. Before we go to that picture, one of the things that I like to do is when it is at all possible, if a client has access to some pictures, whether it's electronically or physical, the physical picture of themselves at various stages of life, and doing that collage, putting those pictures in a collage and talking about what happened or what was going on in their life during that particular season of their lives may help us to get in touch with some religious practices that they may have, some family traditions, or at least open the door up for some conversation about those things. It may even reflect musical preferences, a picture where they were at a festival or at a social gathering. And so that not only are we getting to know them, but it's developing a rapport, because they're getting to realize that we care about what matters to them, about who they are. All right, let's take a look at this picture. I want you to identify one aspect of this picture that really bothers you. It bothers you to the point of activating your pet peeve. And we're going to take some time to talk about that. So take a real good look at the pictures. Everybody on board with me? Unmute yourselves and let me know you're studying the picture.
Nicole is studying the picture.
All right, thank you.
Johanna is studying the picture.
I am as well.
Okay.
Yeah, me too.
Okay.
I am, but I have, does it have to be a pet peeve?
It doesn't have to be,
Oh,
but,
okay.
but if it does hit a pet peeve, make sure you identify that.
Okay.
Mary, are you with us?
I'm sorry. Did you hear me?
No, I didn't.
Okay, yes, I'm studying it.
Okay,
You
Tassie?
don't want us to write anything, just talk about
No,
it.
because I want you to verbally communicate what
Okay.
it is that bothers you.
Okay.
If you're ready, go ahead. Raise your hand.
Oh, okay. Raise your hand. Let me see.
That's
Raise your
okay,
hand.
Mary. Just go ahead. I'm listening.
Okay. Okay. Well, one pet peeve of mine is how the house is so unorganized. Looks like food on the floor, children. Well, not so much the children because they're going to play, anyway, but just the order of the home, food everywhere, things out of place.
Okay, so disorganized.
Disorganized, yes. That's one of my pet peeves.
Okay, all right.
So mine's on almost the same, but the exact opposite end of that. So when, like she said, when there's kids, I'm expecting that kind of chaos. What really bothers me is that mom is in the middle of the picture looking calm, collected, and completely pristine and clean white.
And what was the end? You said, and completely what?
In pure clean white. It just really bothers me.
Okay. All right. So are you saying the disorganization doesn't bother you as much as mom
Nope.
being?
Yep. As mom being just perfect, pristine, just standing there like nothing's going on. Because I mean, like she said, the kids are going to create chaos that can be cleaned up later. That part I'm used to. But mom being calm, cool, collected, clean in the center, no.
Okay. So is that a pet peeve?
I wouldn't necessarily call it a pet peeve. It just bothers me. Because again, I guess it goes to like what my expectations would be. It bothers me, but I wouldn't really call it a pet peeve. No.
Okay.
Pam, just to say the reason it kind of gets under my skin, I was raised, my mother had saying, a place for everything and everything in its place. And that was the rule of the house.
Okay. All right. Let's see. So I got Ariel and Mary. John.
Was that for me?
Yes. John, right.
Yeah, I agree. I don't think it's a problem, but mother standing there letting the chaos happen around without looking like everything is okay. I agree. That was kind of the biggest thing that stood out to me. I guess in looking at it a little bit deeper, where dad's missing in the picture as well. And I don't think if dad was around that whole situation would be going that way. So that's just digging in, scaling it back a little bit deeper.
Okay. So you saying maybe if dad was there, he could bring order.
Well, I don't know with that situation if dad could bring order. I think there's a lot more that might have to go on. That's some baby kids going on there. It sends a bad message. You've got mom there, calm and collective, like the other person said, and you've got this other thing going on. I don't know any household that would look like that.
Okay. Joanna.
I think the part where just some of the unsafety of the kids, like the one on top of the island, and then the kid swinging from the chandelier or whatever it is in the middle of the light fixture, that for me is a pet peeve, just safety issues. So, and again, the same thing, just repeating, she seems calm and collective, like it's not a problem.
Okay.
Mm-hmm.
Patrick.
Yeah, it's too, my pet peeve is too messy. It's chaotic.
That's a pet peeve.
That is, I couldn't live like that. It would make it would make me think that I'm out of control emotionally.
Out of control.
Okay. Thank you. Carolyn.
Yes. Okay. I'm looking at this and I know people saying it's chaotic. I don't know whether this is a one-time incident because I'm looking at this and all I see is Celia all over the place. It's not like she's a messy person or thing because I'm looking at her and it appears that maybe they had Celia and then it just got over every place. And my only concern is that, like the other person say, is that maybe my concern is it's about the kid on the island and the other one pulling on something that's maybe a chandelier. But what I'm looking at, when I look at the other part of the house, when you look past the island and you look at the stove and the other part of the house, it appears to be clean. So I'm looking at Sarah, was this a one-time incident? Did something happen? That particular incident. So that's all I can see. I don't see a pet peeve. And maybe she's gonna say, you enjoy this because you're gonna clean it up later.
Okay. So you don't see her as a messy person all the way around?
No, I don't. Because the picture's not off the walls. I mean, I see the other part of the house and appear to be clean. So I'm saying just one spot, no.
Okay. Okay. Let's see, Nicole.
Yes, I'm here. Before I could pinpoint a pet peeve, this picture just made my anxiety rise so high. It just has a lot going on. I would say the disorderly look of it all, the messiness bothers me. But I also have 4 kids and I know how quick it can go to a mess like that too, so.
Okay. Okay. Tassie. Tassie, are you there? Ariel.
Yes.
So what you think? Oh, I got you already. I'm sorry.
Yeah, I was gonna say.
Right, I got you already. Taylor.
Yes, I'm gonna have to say, going off of what somebody had also said already, the safety issue with the kids sticks out for me the most. Not even just the disorganization, but the fact that the mom is just standing there watching her kids swing from the chandelier and just casually has a smile on her face. That's a definite pet peeve of mine, is safety issues.
Okay. All right. Mom's not alarmed at all.
Right.
Latasha.
So for me, it's the little one hanging off the chandelier. Like the whole mess gives me anxiety, but him hanging off the chandelier, and the one standing on the counter, both kind of my heart pump real quick. So they make me very nervous. I'm very nervous. So those will be my 2 specific.
Okay. All right. Who am I missing? Erin.
Yes. Hi. So I just had a baby, my second baby 2 weeks ago. So this picture is like ringing close to home in every way.
Okay.
But yeah, I feel like the mess is super normal, but just like the way that she's pretending that it's fine, or it should be fine, or she should be fine, regardless of what's going on, drives me crazy.
Okay. So I think the most common response was the messiness and the safety. Nobody said anything about these two fellas in the back throwing cereal, the whole bowl, milk and all. So, you know, we look at this, and I think the most common assumption here is that she's mentally stable. And that may be an incorrect assumption. She may not be mentally stable. And so for her, this is not abnormal. We may be there because someone's there because someone took the picture. We may be there as a mental health professional or a case manager, and part of our job may be to assess her capacity to handle her family. I mean, there are so many different possibilities here. She could be just coming in from work. Somebody mentioned the husband. John mentioned the husband. She could be just stepping in from work, threw on the apron, got the iPad in her hand, having to sign off on something real quick and set it aside. Dad just left to go to work, and this is what she stepped into or walked into. It's just so many different ways to look at this picture. And the thing is what are we looking at it through? What is in our prism and that we are viewing this through? When you talk about a prism, a camera has a prism, and if you adjust the prism or clean the prism, you see differently. And so we want to be mindful that culturally we may be looking through a prism that is not necessarily giving us the opportunity to engage with our clients, with their culture and their history, their health. And we're not just talking ethnicity. We're not just talking in regards to that, race or ethnicity culture, but we're talking about those social cultures, health, education, and so going into this, stepping into, going on a house visit, walking into this, we don't want to be quick to judge. We want to find out what's going on, how this happened. How do you feel, the client, how do you feel about what's going on around you? I did this training before, and one of the participants was not bothered by it at all because she was from a family of 8 children. And so it was pretty common for there to be chaos. And with the exception of the unsafety, everything else can be cleaned up. But this mother not paying attention to the swinging from the rafters and, the little fella getting ready to fly off like Superman off the island, that lack of safety. I mean, these are things that a healthcare professional might be able to help her get a handle on some things or get her some help in there to help with the children. The other thought I had was that these may not all be her children, and it might be a one-time or an unusual incident where the cousins are over and it's just all over the place, and she really can't handle 6, 7 children at one time, and may need to take a look at her capacity, her inability to allow these many children in her home by herself at one time. So it's so many different ways to look at it. And I thought this was a good picture to take a look at, because it gives us all a chance to kind of deal with our first reaction. Somebody said it made them anxious. Nicole said it made you anxious. Latasha said it made you nervous, the lack of safety here for the children. And so this is how we would look at it and assess to see where we can help, but be careful that we don't judge based on, like Mary says, she understands why it's a pet peeve of hers, because she was raised in an environment where everything had to be just so and in its place. Any comments?
Well, I can say this. My daughter is a director, and she works sometimes with foster care. And sometimes people go into people's home, and people have lost their kids because they report incidents like this because of their thinking, you know, I call it their thinking pattern, and they'll report this back to social service sometimes. Sometimes people have lost their kids because of
Oh, yeah.
incidents like that. That's why I say that you have to think sometime about incidents. Sometimes this might be a one-time incident, and sometimes, you know, it might happen a couple of times. That doesn't mean this is an always.
And can we lend some help that would,
Yes.
in terms of educating, in terms of, you know, some help? Does she need someone to come and make a house visit on a regular basis and help tidy things up?
Right.
Or, you know, where's the weak link in her abilities, in her capacity? Can we offer resources? Remember, we talked about capacity is resources plus readiness. You know, can we offer her resources and readiness? You know, help her to become ready to put these resources into action to develop capacity. How ready are we to help? You know, is our organization competent, culturally competent, and able to step in with time, to take action, to help this client, not just give her a list of resources, but step in to help her meet these appointments and get the resources that she needs in order to build capacity to handle her life situation.
Yeah, can you hear me, Pam?
Yes.
Yeah, I just want to get this thought out. I think looking at this picture, it's very important that we, as like you said, counselors don't go in and judge, you know, because just looking at this picture, you know, my first insight is, what if I walked in a house like this and saw all this, you know, I mean, I'm a little nervous, even just, I mean, everything is just out of order, and it kind of makes me nervous, you know, and I guess I would probably go in, if I went in with a judgmental attitude, like, oh my God, something is wrong with this lady, you know, we got to get her out of here, get these kids, you know, and we can't, as, you know, counselors, clinicians, or where to go into an atmosphere with that type of thinking. That's why we need rules, you know, and regulations to help us to sort out things, you know, so that we will give that individual the best treatment, as opposed to judging, you know, and
Yeah.
you know, red
Yeah.
flagging, and, you know, these kids need to be removed from here and she needs some help, you know,
Yeah.
because you actually see these type of settings when you go into homes, and you have to know how to clear the clutter to get to the real matter of the situation before
That's
you
good.
judge it, you know.
Yes.
You know, I just wanted to say that.
Thank you, Mary. That's good. Clear the clutter to get to the real matter. That's really good. All right, a couple of more slides and then we'll go to lunch. So cultural humility. Cultural humility requires honesty to admit that you couldn't possibly know everything about another person or their culture, since culture is an expression of self and a process of learning about the culture of others. The young lady in the video that we watched, the first young lady, she said that even within the culture, there were cultures. Even within the Somalian culture, there were subcultures, and she said like even neighbor to neighbor, how they dress would be different, and those similar but different, the foods that they enjoyed, the foods that they ate. And so if that's so within a culture, there's a culture or cultures, how much more so do we realize that culture is an expression of self and a process of learning about the culture of others? And so we have our culture, and then we want to realize that our culture is not everybody's culture, and their culture is as important to them as our culture is to us. Open-mindedness to learn, allowing the client to be the expert regarding their personal culture, because our personal identity is rooted in our own history. It's important to realize that some people's cultural beliefs may be more important to them than your cultural beliefs may be to you. And I say that because not all cultures focus on their culture. Sometimes our cultures don't even, people within the culture don't even realize that it's a cultural thing, that certain things that they do. For instance, Patrick, you talked about the older woman that offered to cook you some greens.
Yes.
We don't always realize, if I offered to cook you some greens, it might be because I like greens and I figure you might like my greens. It might not even be that I think about greens being a cultural thing with African Americans.
Right.
You know, it just may be a like, a preference. But what we want to realize as generations have, generationally, from one generation to the other, one of the things that I realized culturally is that there's some things that have been lost. And so as a young culture, say maybe a clinician in their 20s may not, and I'm talking African American because that's what I know best, may not even be culturally sensitive about their own personal culture. And if a person is not personally sensitive about their own culture, they may not realize that others are culturally protective or sensitive about their culture. So they may not see the need for the respect. Am I making sense?
Yes.
So we want to be honest when we get honest about our inability or our lack of knowledge concerning another's culture. It's humbling. It's humbling. Patrick, you expressed that well when you talked about not understanding what the clients were talking about with chipping. Open-mindedness to learn, allowing the client to be the expert regarding their personal culture, because our personal identity is rooted in our own history. Being open-minded, that's humbling. And then being willing to put on hold what I think I know about the culture of others. I think it was Carolyn talked about, taking for granted that what we see in the media portrayed about a culture is actually what's true about that culture. That's assumption that we can't afford to make. So we want to put what we think we know about that culture on hold, those basic generalizations, and allow the client, again, to be the expert regarding their personal culture. So here's an example of cultural competence without cultural humility. In African, I don't have y'all on the screen share. Hold on. All right, give me a second So here's the cultural humility that I was just speaking of. So these are the three areas that show forth cultural humility. It requires honesty, it requires open-mindedness, and it requires willingness. So here's an example of cultural competence without cultural humility. An African-American nurse is caring for a middle-aged Latino woman several hours after she'd had surgery. A Latino physician on a consult service approached the bedside and, noting the moaning patient, commented to the nurse that the patient seemed to be in a great deal of post-operative pain. This person has had an operation. The nurse summarily dismissed his perception, informing him that she took a course in nursing school in cross-cultural medicine and knew that Hispanic patients overexpress the pain that they are feeling. The Latino physician had a difficult time influencing the perspective of this nurse, who focused on her self-proclaimed cultural expertise. So the nurse missed the opportunity to learn. We talked earlier about the importance of taking the opportunity to learn about another's culture. She exercised judgmentalism. She had a biased perspective. She was prideful in her cultural competency ability. Therefore, she was not humble. She didn't have cultural humility, the opposite of which would be being prideful about her own cultural ability. And sadly, this is not an uncommon behavior. I had pancreatic cancer in 2010. And so since then, I've had 3 or 4 bouts with pancreatitis. And pancreatitis, if you've ever had pancreatitis, you know, pancreatitis make you want to take something and cut your whatever it is that's in there hurting out. And it's just so horribly painful. So during the opioid crisis, I had an episode and I went to emergency and I went to the hospital in the suburbs in Bloomfield. And I was treated really disrespectful. And I felt that I was stereotyped. They didn't want to give me pain medication. Needless to say, my pain was so great, I clowned. I had a fit on them. And they gave me what I needed because I felt like I was dying. And but I felt discriminated against because of some of the ways that I was treated. And I know it was an opioid crisis, and I understand that. However, we want to be careful how we treat people. Any comments on the story? Okay, we're going to get ready to go to lunch, and we'll come back and jump into module 2, becoming culturally competent, and look at the cultural competence continuum. So sign out, please. Sign out for lunch and sign back in when you return. Sign out in the chat and sign back in when you return from lunch. We'll be at lunch for an hour. So it's just about 12 Eastern time, 11 Central time. So I'll see you back here in 1 hour.
Come on,